Welcome to Nursing 150. Nursing 150 is a fast-paced, high-energy course that focuses on medical surgical nursing. The practice of medical surgical nursing requires some special knowledge and clinical skills to manage actual or potential health problems that affect individuals. Typically, it also affects their significant others and the community. It's typically older adults, 18 to age 100 years of age. Medical surgical nursing is practiced in many types of care settings. Acute care settings such as hospitals, some skilled nursing facilities, home care agencies, and ambulatory care clinics. The role of the nurse in these settings includes care coordinator, caregiver, patient educator, is a big role of the medical surgical nurse, and we'll talk about that a lot throughout this course. Patient and family advocate, that is another major role of the medical surgical nurse. We have a very big role as educator to teach promotion, health promotion, to teach healthy lifestyles, to teach preventive measures, and also involving the family as well in this teaching. A lot of this information that I'll talk about in this presentation can be found in your medical surgical textbook. They're all basically in, looks like chapter 1. I know some of this is just a review, but it's good to just kind of bring this all forward and be familiar with it and have it fresh in our minds. So that's kind of why I created this just short little presentation to just kind of revisit some of these concepts and thought processes and reintroduce us to the medical surgical nurse. And this slide is just kind of a list of things that we'll talk about regarding each module. We'll always talk about promotion of health, prevention of illness, and then talk about these basic needs or concepts that the patient has. These needs or concepts are kind of introduced to you in your Fundamentals of Nursing course. This course will build on those concepts and focus on the role of the nurse in safely meeting the biologic and physiologic needs of your patient. We will also add to these concepts or patient needs the thought of the patient's psychological needs, their cultural needs, and spiritual needs. Some common concepts that we will discuss throughout the course include protection, oxygenation and tissue perfusion, mobility, sensory perception and cognition, nutrition, metabolism, bowel elimination, urinary elimination, and sexuality. You might have heard, these might sound familiar. Hopefully you have heard of at least half of them in your fundamentals course. We will continue to build on understanding these concepts or patient needs and how, as a nurse, it is our job to identify these needs and to be able to do interventions, to apply interventions that can help with these patient needs. A big thing is prioritization as well. We need to really kind of identify these needs and then prioritize their most common need, their most important need, and address those and identify interventions that can help us to take care of that patient. The concept of safety will be one of the major concepts that we will always talk about in every module throughout the course of Nursing 150. The concept of safety is regimented and monitored closely by some of the agencies that are listed: the Institute of Medicine, the Joint Commission, National Patient Safety Goals. Nurses who practice medical surgical nursing must have a broad knowledge to meet the needs of their patient. There's been a lot of advances in technology. The patients that we're taking care of now are very sick. Most of the patients that are in the hospital are there because they are extremely sick. They're more sick than they used to be. And so these agencies such as the Institute of Medicine and the Joint Commission have put forth standards by which each facility should practice. It's evidence-based information. For instance, the Joint Commission is an agency that comes in and accreditates agencies who choose to have them come in. And we have to meet the standards of the Joint Commission in order to say we are Joint Commission accredited. And that just shows, when we can say that and put that on our front doors, that just shows the community that we have met these standards. And these standards a lot are about safety, about safe care of our patients. That we have these policies and procedures in place that meet the standards of the Joint Commission, and therefore we can say that we meet these standards and that we are a safe institution. Every year, the Joint Commission publishes national patient safety goals. These goals are based on their surveys of institutions across the country. They identify common problems across the country. For instance, falls typically is on this list. Safe drug administration is typically on this list. Healthcare associated infections are usually common problems that we struggle with across the country. And so Joint Commission will call these their national patient safety goals, and when they come in the following year to do their surveys, they will really focus on this list of national patient safety goals. You can find this list every year. You can just Google the Joint Commission National Patient Safety Goals, and that will come up, and so you can see what those priorities are for the year. Like I said, this is based on their surveys from across the country, that they've identified some very common problems that's happening across the country, and so they're basically trying to use this as our standards in order to make sure that we're providing safe patient care. Rapid response team is this kind of was developed as a result of some people doing some research and identifying that if we could create a team that could come out and help and be another set of eyes to the healthcare team in the event that they're concerned about a patient. This has significantly decreased the amount of codes outside of the intensive care unit, which has significantly increased patient outcomes. So we always had a code team, and so if we come across a patient who was actually coding, which means no breathing, no pulse, things like that, the code team would come and help. Again, after much research, these rapid response teams were formulated to be able to call them prior to that code situation, because they found out if we could get this patient stable before they code, well, the patient outcome is going to be much better for that patient. So this has significantly been very successful in institutions across the country that have implemented the rapid response team. And again, this is based on evidence-based practice, which is the next on our list here of topics. And pretty much evidence-based practice just means that we are basing our practice based on the evidence, based on research. There's been research to back up how we do things, why we do things, which makes our profession more validated. It makes our profession seen more as a profession, not just a skill. We do our own research now. We base our everything that we do on research. So it makes it more safe, and that's all the idea of all doing that, is being more safe. The concept of SBAR communication, you've probably heard that before. The concept of SBAR communication was developed, again, based on research. This was based on the fact that we truly have a history of poor communication between professional caregivers. And so they developed this organized way that we should put our information together so that we don't forget things, and that we all communicate in a similar manner. The National Patient Safety Goal mandated that nurses communicate patient care needs using the SBAR form around 2006, I think. And to improve communication between staff members and healthcare agencies, procedures for handoff communication were established. An effective procedure used in many agencies today is called SBAR, and which stands for Situation, Background, Assessment, and Recommendation. We will talk about SBAR communication throughout this course. You'll talk about it a lot in clinical. We need to develop a very organized way to do SBAR, and it's just a much better way to communicate and being very thorough, and it's just helpful if we can all sort of communicate in a similar manner so that we are all on the same page and things don't get missed about our patient. One of the concepts that comes up very frequently when we talk about safe nursing practice is the practice of delegation. We know that nurses are very busy, and we're asking more and more and more of our nurses, more tasks for them to do. And we do work very often with an unlicensed assistive personnel, such as a patient care technician, a PCA, patient care assistant. I think that's what we call it at the hospital here. But delegation is the process of transferring to a competent person the authority to perform a selected nursing task or activity in a selected patient situation. The process requires precise and accurate communication. The nurse, this is the main point here, the nurse is always accountable for the task or activity that is delegated. So, and that's kind of highlighted here. So the key concepts are, you have to, if you delegate, you absolutely can, and we have to delegate so that we can get everything done for our patient. But we have to make sure that we're delegating to a competent person. Before we delegate the task of blood pressure, maybe just obtaining a blood pressure, we need to make sure that that patient or that unlicensed professional is adequately trained and is competent in doing that. Once we do that and we delegate the task, once the task is performed, it's up to the nurse to follow up and make sure that the task was performed, and look at the result of the blood pressure, and it's the nurse's job to follow up on that. So there are 5 rights of delegation. I will say that, again, this is a big thing with safe nursing care. I do know that NCLEX likes to ask questions about safe delegation. So the 5 rights are the right task. So that means that the task is within that unlicensed professional scope of practice and competence. They've been trained. An example of that is, I know that some of the unlicensed professionals at Christ Hospital, for example, can draw blood. Not all of them can, but some have been trained. So before I would be able to delegate that task to one of them, I'd have to say and clearly clarify whether they have been trained to do that or not. I have to know that for sure. If they have been, if they've gone through the proper training and have done the proper channels, then I can delegate that task to that certain unlicensed professional. If I were to not ask that unlicensed professional and not to confirm that they are competent in that task, and I try to delegate it to them, then I have inappropriately delegated that task to someone who cannot do it. And that would be something that I could be held accountable for. Right circumstances, so this is patient care setting and resources are appropriate for the delegation. So the unlicensed professional has to have the appropriate tools and things like that. Right person, that means they're competent to perform the delegated task or activity. Right communication. The nurse this is very important, the nurse provides a clear and concise explanation of the task or activity, including limits and expectations. So it could be like, could you get that blood pressure for me in room 2010 on Joe Smith? I need that blood pressure in the next 10 minutes. Once you have gotten the blood pressure, I need you to report it back to me. Please report it back to me in the next 10 minutes. So that's a very clear, I need who I need it on, what I need it on, and how quickly I need it. So those are kind of examples on how to communicate that effectively. Right supervision, and again, that means that the nurse is evaluating and monitoring and supervising whether that task was actually done, and then doing the follow-up on what the result of that task. We may be delegating tasks to licensed practical nurses who are nurses. They do have a license, but there are some things that in some states they are not able to do. So we have to make sure that we are aware of what those laws are in that state in which we practice and be able to delegate to them appropriately. One of the major roles of a medical surgical nurse is to take care of patients pre and post-op in a surgery situation. You will learn a lot about that in this course. You can find a lot of information about this in chapters 14, 15, and 16 of your medical surgical textbook. And these are things as far as pre-op teaching, getting informed consent, pre-op labs, and diagnostic tests. It's important to be familiar with normal lab values. I know that you talk about that to some degree in your fundamentals class. We will absolutely expand on that. Make sure you kind of carry some of that knowledge forward, because you will be expected to know normal labs. Because the role of the medical surgical nurse is to know that we have to do pre-op labs. And we do that just to screen the patient to see if they have any pre-operative problems, if they, if possibly they have an infectious process going on, then we'd have to call the doctor and tell them that the white blood cell count is high, because that might mean that they cannot have the surgery done. We also do a lot of diagnostic tests pre-surgery. We'll do x-rays, EKGs. Again, a lot of that is just to determine their baseline and to see if they have any pre-existing problems that we may need to address prior to taking them into a surgical situation. So just make sure you review like some of these pre-op labs. Most of them are very common labs that we do. For instance, we do CBC. We do a renal panel to check their kidney function before we take them to surgery. Chest x-ray and EKG are very common diagnostic tests. The chest x-ray will look at the lungs to make sure the patient has healthy lungs before we maybe take them and put them to sleep. EKG looks at their heart rhythm just to make sure that they don't have any heart abnormalities. Sometimes a stress of a surgery can be very harsh on a patient, so we want to identify if they're going to be able to safely tolerate a surgical situation. We also are going to learn a lot about preparing patients for diagnostic tests. We're going to need to know whether they are NPO, whether they can eat or not prior to the surgery. So a lot of our job as a medical surgical nurse is pre-oping patients. So we will talk very extensively throughout the course about certain tests, diagnostic tests, and how to prep our patients for them. The other thing about doing pre-op teaching and pre-op care of a patient for surgery, we also assist sometimes with a surgical checklist, a safety surgery checklist. That's called a timeout. That's another Joint Commission and World Health Organization implemented procedure doing a safe timeout, and that's making sure that we have the right patient, the right limb, the right surgery, making sure we have any allergies identified. Again, all of this is about safely taking care of our patients. You've probably heard the nightmare stories of when patients have come out of the OR and it's the wrong patient, they maybe amputated their wrong limb or something like that. We have to be able to implement safety procedures to stop those kinds of things from happening. And so that's why, like, again, safety. You're going to hear a lot about. And so this presentation is just to kind of give you, again, a summary of what to bring forward and kind of introduce you to what's up ahead. So again, preparation for Nursing 150. Make sure you kind of are familiar with those labs. We'll expand on that a lot more in your clinical situation. Some common diagnostic tests just to have some idea of how to prep a patient for these, and just kind of read over and review some of that material to bring forward with you. I look forward to a great semester with you. I look forward to further discussing all of this information, and really my passion is to provide you the information and the tools to take safe care of your patient and to feel confident that you can safely take care of your patient when you get out there on the medical surgical floor.